This is Fernando Martinez again, Chief of the Division of Pulmonary and Critical Care at Weill Cornell Medicine in New York City. Again, apologizing that I could not be there in person, thanks to COVID and the gift that keeps on giving. I've had to remain in New York City. Hopefully we'll see you in person next year. This current presentation is on acute exacerbations of IPF. And it's a difficult with a limited amount of really good data, but the data that are available does an opportunity on giving us a sense on how to approach patients with this particular manifestation. Here's an example of one of my patients who was a 72-year-old man, came into our emergency room and gave a 3-year history of cough and then rapidly progressive shortness of breath for just the last 3 days. I want you to remember this 3-year history of cough and then this rapidly progressive breath for 3 days. His past medical history was hyperlipidemia, for which he's on statin, postnasal drainage, for which he's been on phenoxidine, very mild reflux, for which he's been on ranitidine. He smoked a long time, but stopped smoking 20 years ago. He has a family history of diabetes and heart disease, and at the time he was in the emergency room, he was tachypnic, tachycardic, and profoundly hypoxic. His initial chest X-ray at the time seen in our emergency room shows diffuse infiltrates, which were where he had evidence of fibrosing change, traction bronchiectasis with superimposed significant ground glass opacity that's multifocal. He came into the emergency room, was intubated, was on a mechanical ventilator, and died within 5 or 6 days of what was felt to be an acute exacerbation of idiopathic pulmonary fibrosis. It's really a bad complication of this disease, and it is one that requires careful consideration for its evaluation. So some of the general concepts that I want you to keep in mind is that this concept of an acute exacerbation of underlying disease has been defined across many progressive fibrosing lung disorders, IPF being one of them, but across all of the fibrotic lung disease, you can see this. And generally, the definition has been the symptoms, the respiratory symptoms and the respiratory deterioration in less than a month or so. And then there are new bilateral changes on a computer tomography of the chest. One of the components that relates to this has been that over the last year or two, it has been acknowledged that exacerbations of IPF have a profoundly bad outcome, that acute exacerbations of non-IPF fibrosing disorders are also bad, but not as bad as. So in fact, you can see these same clinical events in a broad range of fibrotic disorders, but they're particularly bad IPF, which is why we devote so much time to worrying about how to manage this component in IPF. There have been multi-investigator attempts to provide working definitions. The two most frequently utilized are those that we developed modified about 6 years ago in a multi-investigator fashion. And so we had queried a whole series of our colleagues, as Hal called the ones who ran both of these projects, and came up with some areas where there was agreement. In the case of diagnostic criteria for acute exacerbations of IPF, a previous or concurrent diagnosis of IPF, I just showed you, his diagnosis was made at the time of his acute exacerbation. But hold that thought, we'll come back to that again later. An unexplained worsening of symptoms within a period. This has been debated, and we debated this in these. Not everyone thought that a month was the optimal time. Some thought it should be 2 weeks. Some thought it should be 6 to 8 weeks. We compromised to about a month. Is not a criterion that has come from God. It's a criterion that was a compromise criteria amongst a large number of clinicians and investigators. There was an agreement that you needed to have an abnormal CT. Nothing else obvious as the cause. When we revised these criteria, we stuck to the month, but we also wanted to ensure that clinicians with input that if there was a clearly obvious for this patient to be seen with respiratory distress, if they had a pneumonia, a pleural effusion, a pulmonary embolism, that we did not necessarily think that that should be categorized as an acute exacerbation, but just an acute respiratory deterioration that was not an exacerbation. Provided guidance regarding the potential of sort of merging these concepts and saying, if you have a patient with IPF who has a rapid deterioration, don't see anything obvious initially, and you perform a limited evaluation, including CT, and you don't think there's heart failure, then you could consider two various categories of acute IPF, which we termed a triggered event or a truly idiopathic event. And a triggered event would be if you documented the infection, if it's temporarily related to a procedure, if there was a clear suggestion of the toxicity, or if there was compelling data suggesting an aspiration event. And we suggested that these be considered acute exacerbations of IPF that were either triggered or idiopathic, and then everything else that was a no was. And so the revised criteria that we proposed were criteria of an acute deterioration, of previous or concurrent diagnosis of IPF. This is the rapidity month criterion was somewhat arbitrary, and then no other obvious explanation. We didn't have a lot of data when we made this recommendation but it has had an influence in terms of how clinicians practice. This is a survey that took place of multiple specialty and non-specialty centers around the globe, where they were queried across a series of topics. This happens to be, what do you do diagnostically, since we're and diagnoses, and you can see that almost everybody uses CT, select bronchoscopy. Some people use KL6 and induced sputum. Urine is for atypical infections, as are some of the nasopharyngeal swabs that can be diagnosed for influenza or RSV, for example. And there's some difference between a specialty center and a non-specialty center, but some of these criteria, some of these recommendations were based on what we had recommended in 2016. That there have attempts now at trying to provide some insights regarding what we proposed in 2016 and whether this diagnostic classification had any prognostic significance, for example. So a large retrospective study, a couple of hundred patients with known IPF, 122 respiratory hospitalizations, of which were not acute exacerbations. So these were pneumonias or clear-cut lower respiratory tract infections. So again, trying to follow in our component of acute respiratory deterioration, triggered versus non-triggered. And in these individuals where there was not an obvious alteration, it was an acute exacerbation of IPF. And so the group was able to provide some insight as to whether our prior characterization that included an alternate event or trigger or not is what this group has allowed some data. And what they recommended was the following. And I think this supports some said, but not other components of what we said. So this is survival time over the course of in patients where there was a clear alternate diagnosis, action. That person was considered to have an acute respiratory deterioration that was not an acute exacerbation. They clearly had a better than those that had an AE IPF. All right, so that's good. So that separation is helpful. The idea that you could have an idiopathic versus a triggered event wasn't as helpful. And in those situations, it was clear the diagnosis was equally bad. So that provides some guidance that one of the made in 2016 may not have the strongest data. Just I think developing a clear-cut alternate explanation is probably the most important thing. The rest may be less relevant clinically. There have been a series of additional studies that have come from industry registrational studies. This is one that Hal published from the nintedanib pivotal study in IPF, where there was a category of investigator report observations or a committee adjudicated confirmed event. And they just sort of looked at what would be the risk factors for developing an acute exacerbation in these two categories in that clinical trial. This is a clinical trial population. And so there are a couple of things that I think were interesting and important to remember. The lower the FVC, the higher the risk. And so the more advanced the patient's disease, the more likely they are to have these events. If you are randomized to, in this particular study, nintedanib, the risk of events was lower, suggesting that may have a beneficial effect on preventing these events. We'll come up with that concept a little bit later on as we proceed. Suggestions that the worse the disease, here's a mark of the disease, the higher the risk of having one of these events. This does provide guidance. It's very practical for a component later on during the discussion. A separate group also looking at the same data sets from the intended therapeutic trials also characterized exacerbation and adverse event reporting, suggesting that most patients did not have, the vast majority of these patients, a smaller number had these acute events during these relatively limited time periods of trial. And the majority of those events were exacerbations that were reported as a serious adverse event, meaning the patient was hospitalized. And you can see that they had a really bad outcome, as you'd expect. But there were also acute that were reported that were non-serious adverse events, meaning that people did not get hospitalized. And that was a relatively small number out of these large studies, but suggesting that investigators at least may feel that something fits our criteria of an acute exacerbation, but may not require hospitalization. It doesn't happen very often in this particular series of studies, in about 20% or so of these acute respiratory exacerbations. So interesting of information. I think what I've taken out of this is that there's a strong suspicion that an antifibrotic can prevent these events, but it also, the more advanced the disease process, the more likely that that patient is going to suffer one of these acute exacerbation events. So this topic comes up again in one of the points that I'd like you to remember from this presentation. There have been a series of our Japanese colleagues that have suggested that the pattern of abnormality on CT has prognostic implication. So if there are peripheral patterns, multifocal or diffuse patterns, and I'll show you two of my patients from Michigan from the past. A patient that has more focal abnormalities in areas that you can see a rapid deterioration symptomatically and radiographically over a month. So this fits the criteria. So this is a person that has a more focal pattern, and this is a person that has a very pattern. And so this has some interesting guidance. And it's been confirmed by other groups in other countries. I'm not exactly sure how you would make major therapeutic decisions based on these abnormalities, but it's a piece of information that you may use in deciding therapeutic interventions. So one of the disadvantages of this whole discussion has been the fact that viable therapies that are well studied are actually pretty uncommon. To begin with, and there are attempts right now to establish large multi-center consortia that could do appropriately powered clinical trials. The general recommendation, really based on weak data and opinion, is sort of highlighted by this series of recommendations in the European Respiratory Review a few years ago, where in people that required ventilation, sort of this low tidal volume ventilation, the ARDS net low tidal volume approach was recommended. Non-invasive ventilation, if you could get away with it, or high. Very, very little data for any of these in this acute clinical setting. These are really extrapolations from other related disorders, heart failure, pneumonia, and this is sort of extrapolation from ARDS. There are some relationships. ARDS is diffuse alveolar injury, which is what we see in these patients if they're biopsied or after they die on autopsy. So I think it makes reasonable sense to extrapolate from these disorders into acute IPF. The pharmacology is really quite interesting. That there are no solid data in a randomized control fashion for steroids or the dose of steroids. We all but I can't tell you that there is a huge literature with randomized controlled trials that strongly supports steroid or a typical type of steroid. It's even worse for some of these other components, empiric antibiotics, immunosuppressant medications, thrombomodulant, for which there really is not a lot of compelling data. I'll show you some recent data that does provide some additional guidance for some of these therapeutic options. Lung transplantation remains one of the components that I think all feel is probably one of the therapies that would have a beneficial effect. Not really well studied. Those of us that have been in transplant for a long time, it's a bias that we've developed over a period of time. And then other approaches, which I will address as well to some extent. So when you think about the data sets that are available for therapeutic options, the component that seems to be most for most of us have been using some form of parenteral steroid. And usually it's methylprednisolone. So again, this is from that same survey that I showed earlier from specialized and non-specialized centers around the globe. And you can see that most clinicians use steroids in some fashion. And I think all of us do this routinely. I can't tell you that there is a magical dose that we use. I don't think most of us go with this 1,000 milligrams of solumedrol, methylprednisolone anymore, because it seems like a really high dose, but some version of methylprednisolone is generally what's used. I think most of us consider using antibiotics because it can be so difficult to clearly define one of these triggered events from infection from a truly idiopathic case. These patients are too unstable to undergo fiber optic bronchoscopy with BAL, and so I think it becomes less clear cut when there's a clear infection, and so most of us tend to use empiric antibiotic therapy. Some only use it if there's a clear sign of infection, but that between the clinical picture and a clear sign of infection can be nebulous. I think that the second component that's become challenging has been SARS-CoV-2. COVID-19. There are clearly data that COVID-19 can precipitate these events, and so there are now a series of therapeutic algorithms for the treatment of COVID-19 infection, including the use of steroids, including the use of antiviral agents, and some more targeted immunosuppressive approaches. And so I would defer into algorithms for COVID-19 therapy, even in these patients that have don't have a huge amount of data to support that, but I think it's sort of been the most of us have had in this field. There have been a couple of recent attempts to provide more definitive data. So this is from a multi-center European consortium that tested in a reasonable sample of patients placebo or cyclophosphamide, so one of the immunosuppressants. And I reviewed this manuscript, and it's clear that there was no benefit. So this is cyclophosphamide versus placebo. This was not good. You could make a strong argument that this level of immunosuppression routinely used is probably not a good thing. If you look at death in 3 months, population, all of these numbers are higher for cyclophosphamide than placebo. And so I think that if anything, that it is not worth giving intravenous cyclophosphamide in a person with acute exacerbated IPF. I think it just doesn't provide any benefit. So I'll show you some data that modified the previous recommendations, and one of them has been cyclophosphamide. Not a good thing to use. Was something that was felt at one point to be of great interest. There had been a retrospective cohort study suggesting that thrombomodulant was a good thing. Alas, a placebo-controlled randomized trial was published in the Blue Journal about 1.5 years ago, with the overall effect for placebo or this particular therapy being to this side, favoring placebo and not the active treatment. And so again, not something that supported a tremendous beneficial effect of therapy. And if you looked at a whole bunch of subgroups, really you did get a sense that there was a dramatic likelihood that this particular therapeutic approach, in fact, almost all of these groups favored the placebo arm. Like, this is one of the important components. This is why you do placebo-controlled trials. There's a great suggestion, not confirmed in a properly performed trial. So I think we now have an additional piece of modification to modify that earlier table of suggestions for therapy, and cyclophosphamide and thrombomodulin are now going to have no support for that component. There has been, in a very aggressive approach to addressing a potential autoimmune process in this disease. And so there is a trial of therapeutic plasma exchange, rituximab and IVIG and IPF. There was a pilot study tested in comparison to historical controls. There was a potential benefit with a documentation that some of these autoantibody titers could be decreased. We're doing pilot studies that didn't hold up. So there is, in fact, an ongoing control trial. I updated this as of yesterday. In regards to this particular trial, it is not published, and where this lands, I would not do this outside of a control trial. The last component is acute lung transplantation. There are not randomized controlled trials of this in acute exacerbations of IPF. There are some suggestions that transplantation in an IPF patient who doesn't have an acute exacerbation, or they're in a stable state, does better than in transplanting a patient who is in the middle of an acute exacerbation. If you extrapolate some of the earlier survival curves, which kind of look like this for acute exacerbations, you could hypothesize that there is a potential benefit of transplantation in an acute exacerbation. And if you looked at the causes of patients' death in this group here versus this group here, there's a much broader series of problems that can be seen. So how do I interpret these data? If you're going to transplant a patient with IPF, to transplant them when they're not in an acute exacerbation. I still think there is, in highly selected individuals, the potential of in the setting of transplantation, exacerbation event with the survival at of around 50%, which is better than historical controls of acute exacerbation mortality. And so the reason to me this is important is that lung transplant, one of the therapies that clearly benefits outcome, and it's better if you do that when the patient is stable than when they get. So it's been one of my strong biases for decades. I was involved in recommendation of transplant evaluation guidelines that a patient with IPF, when they're first seen, if they are a candidate for lung transplantation, should be evaluated independent of the severity of disease. So at the very least, the transplant center has seen that patient state and can facilitate transplant necessary. Now, if you see a patient for the first time with IPF, 90 years old, or has multiple contraindications to transplantation, it doesn't become as relevant. But early evaluation of an IPF patient, otherwise would meet transplant criteria, I think is an absolute mandatory event. And these data indirectly support that argument. I think that the last thing I'll leave you with is that given how bad these events are, patients with IPF and for non-IPF progressive pulmonary fibrosis disorders, prevention is really a key component. And remember, I showed this case earlier. This is the same patient that I showed you at the very beginning. This patient when he was 72 years old, presenting with 3 years and several days of dyspnea. It turns out that 2 years he had actually been seen in a setting with cough for a year, very mild, and was treated with azithromycin for a walking pneumonia. At the time, he had normal vital signs and very fine basal crackles, and his chest X-ray already suggested the potential of very mild fibrotic changes. So in hindsight, this is a patient that probably should have been diagnosed earlier, placed on an antifibrotic, because there is a data set that you can, in fact, decrease the of acute exacerbations of IPF over time. This is, again, studies. These were the studies published in the New England Journal of Medicine. This is a grouping of those data where you see what happens to placebo. You see what happens with regards to the likelihood of an investigator-reported acute exacerbation event, and after about 3 or 4 months, you clearly started to see a separation. And so I'm a big fan and a big supporter of early fibrotics once the IPF patient is diagnosed. And the decision of whether to be on an antifibrotic or not is up to the patient and their family. But in shared decision-making, I think it is important to highlight to the patients IPF, acute exacerbations, occur. They don't occur frequently, occur in a few percent. When they occur, they're very bad. Therapeutic options are very limited. And so it is best to prevent these events. And even if that IPF patient is doing relatively well and is relatively mild disease, acute exacerbation, and the patient and the family need to weigh in their mind as they make a decision regarding antifibrotic therapy. Preventing these events is a crucial part of the paradigm. If the patient has disease, lower FVC, may require oxygen, I've already, that's a risk factor for these events. In that patient, it's particularly that the patient and the family realize that antifibrotic therapy will decrease the risk of these acute events in that particular patient. And with this survey across the center, you see that that preventative therapy is frequently used by all of these antifibrotic therapy, vaccination, antacid, complicated setting, but sort of preventative measures like anti-therapy and vaccination become such a crucial part of managing our patients because acute exacerbations occur. They're bad. Good things we can do for them. So preventing them is probably the most important conclusion that I would argue to you that acute exacerbations occur across all fibrotic disorders. They are particularly prognostically in our IPF patients. We've now provided a framework for these events, less than 30 days, approximately a month or so of acute symptoms, no obvious other obvious explanation, and then on the CT with a ground glass or consolidation. I think we now have better data that those criteria do seem to be effective to provide some value. But the therapeutic options that we have are limited. We all use steroids in some form. The other therapeutic options are just not well supported right now. And again, always remember, early for a patient with IPF is probably a key component. And in this acute exacerbation, I think if feasible, and you're at a center that has that capability, lung transplantation can be a life-saving option. But always remember, when you're talking to your patients, because all of these things are true, preventing these events is really the key component of the paradigm of management with IPF, and I would argue of all of our progressive fibrosing disorders. I apologize for not being there in person. I hope to be able to make it to see you next year. You live in a wonderful place, and I look forward to seeing it personally. But for the time being, I hope that this virtual presentation has provided you with some guidance and some very practical points that you can use. Thanks again for allowing me to participate in this session.
I think this was very useful presentation of the acute exacerbation. The next speaker